Hello, and welcome to this latest episode on HIV by Medthority. In this series, our hosts are Dr. Margherita Bracchi and Dr. Borja Mora Peris, who will be discussing the main side effects and challenges of antiretroviral regimens. All opinions expressed in this podcast series are those of Dr. Margherita Bracchi and Dr. Borja Mora Peris. Over to you.
Hi, welcome to the HIV Podcast Series Discussion. Today, we are going to be talking in this second session about the main side effects and challenges of antiretroviral regimens. My name is Dr. Borja Mora Peris. I work as a consultant in sexual health and HIV at Imperial College Healthcare NHS Trust in London, and my colleague is Dr. Margherita Bracchi.
Hi, I'm also an infectious disease consultant and I work at Chelsea and Westminster Hospital. So, Borja, when you see patients in clinic, can you tell me what are the main problems when it comes to side effects of antiretrovirals that you generally encounter?
So, in general, you know that antiretrovirals have become better and better over the years, and they are now much better tolerated, and their safety profiles have allowed us to look into detail into potential side effects that before were actually not that important because we were more concerned about issues related to efficacy and other aspects such as, like, for example, lipodystrophy. At the moment, what we have to focus on is about cardiovascular risk, neuropsychiatric side effects, renal and bone toxicity, and also about, in our case, the potential issues that we can have with drug-drug interaction in a context of an aging HIV population who is normally on polypharmacy. That's something that we have to look into, and from our perspective, we have given recently a lot of importance to issues around the cardiovascular risk and the metabolic toxicity around weight gain. I don't know whether you have any particular tips, but for example, in our clinic, we are pretty worried about the effects of dolutegravir and second generation integrase inhibitors. What is your take on those these days regarding weight gain and cardiovascular risk?
So, weight gain has come up as a new problem, I would say, in the last 3 to 4 years of working as a HIV physician. We know that there is a good weight gain when a person starts antiretroviral treatment, and this is a return to health type of weight gain.
So a healthy gain.
Yeah, a healthy weight gain. And that's actually something that we have to acknowledge and also counsel the patients on. So we know that people that are diagnosed with advanced HIV often also are of low BMI, so low weight, and they will happily gain some weight. But in the context of a person that is diagnosed early, it is important to inform them that there will be some weight gain, despite, regardless of any of the choice of antiretroviral. I think the weight gain that we see is also multifactorial, and it really changes depending on a variety of characteristics that range from the age, the sex of the gender of the patient, as well as genetic characteristics, so their ethnicity, but also depends on factors that are more linked to the HIV infection itself, like the amount of CD4 and the viral load. However, we've come to learn with big trials like the ADVANCE and the NANCEL trials that some antiretroviral might have a protective effect in terms of weight gain, and some others might contribute to a further higher weight gain. And that what we know is that tenofovir DF, so disoproxil fumarate, and also non-nucleoside retrotranscriptase inhibitors like efavirenz might have a protective effect in terms of weight gain, whilst second-generation integrase inhibitors like dolutegravir, especially when combined with tenofovir alafenamide, can have a higher impact in terms of weight gain. And this has been seen especially in specific population like postmenopausal women of Black African ethnicity.
I can see that can be a difficult conundrum that you have to face in clinic when one of the drugs that you are mentioning, the TDF, is also one of the drugs that can very easily cause bone and renal toxicity. So you have to balance several aspects of the risk of the patient out, and you have to think about what's best for the patients. What is your take on those other two issues in terms of like switching antiretrovirals? I'm talking about renal and bone toxicity. Is there something that you regularly check? Do you think that some patients are more at risk than others? Or is there any type of like risk assessment that you tend to do?
So absolutely, we always need to check for any pre-existing comorbidity, but as well as any potential development of further comorbidities whilst people age with HIV. And definitely an assessment and measurement of renal function, including measurement of filtration rate and any detection of presence of proteinuria, are parameters that we check regularly in clinic, as well as liver function. And we use risk assessments or tools to understand what the potential risk of fracture would be, like the FRAX tool, for instance. In general, of course, we would never start a person that has got already presence of renal disease or osteoporosis or pathological fractures on a medication like tenofovir disoproxil fumarate, because we know that that can increase the disease in those organs, and we would seek for alternatives like alternative nucleoside retrotranscriptase inhibitors. But I think that a lot of issues also might come with other side effects that we experience with second-generation integrase inhibitors, like the neuropsychiatric side effects. We normally see a lot of people with mental health issues, anxiety, depression in clinic. Can you tell me a bit more of how you deal with them?
Yeah, indeed. You are absolutely right. I mean, you well know that we have like a prevalence of mental health disorders in our patients that is higher than the non-HIV infected population. The people not living with HIV. And that's something that we are really concerned about. Particularly, we will be avoiding a particular third drug, which is efavirenz, is a non-nucleoside retrotranscriptase inhibitor that has been linked to very kind of frequent side effects, neuropsychiatric, including vivid dreams, dizziness, and also suicidal ideation and attempt. There is also some of the new antiretrovirals that we have more recently discovered or actually linked with neuropsychiatric side effects, such as the second generation integrase inhibitors in particular, even though there might be a family effect, and therefore first generation integrase inhibitors might also have some increased toxicity versus other antiretrovirals. We have some very interesting data from some cohorts in Germany, particularly near Hamburg, where they actually found out that the reason for discontinuation of treatment was linked to neuropsychiatric side effects in almost like 10% of the patients, and that actually that was more accentuated in those patients taking dolutegravir. So that's of major concern, since we actually have dolutegravir as the third drug of choice in the WHO guidelines, and at the moment is a very common drug, not only in high-income countries but also in low-income countries. So it's something that we are looking into, and in particular, there is also extra evidence about the combination of that drug with other drugs. And for example, we have the combination of dolutegravir with abacavir, which has been also reported to cause like increased neuropsychiatric side effects.
And since you mentioned abacavir, it's a drug that we have been discussing a lot about when it came to cardiovascular risk assessment in our patients. So we are not using that medication anymore that frequently in our setting, and as we also have got the potential of switching patients to a combination of just dual treatment, and often we try to go and simplify regimens as much as possible. But when it comes to cardiovascular risk, we know that people living with HIV do have a higher risk of cardiovascular events. Those events might happen at younger age compared to their people not affected by HIV. And what are the messages that you deliver to your patients when you see them in clinic and you assess their cardiovascular risk to be high?
So the first thing that we look into is obviously whether they have a general indication for a statin based on Q risk assessments. And then the other thing that we tend to think about is what can we do in terms of antiretroviral medication. So we also have not only abacavir linked to higher cardiovascular risk, it's also protease inhibitors. We also try to have a great deal of an input regarding their lifestyle, and we refer them to the dietitian. But regarding abacavir, also obviously, not only to the dietitian, but also to smoking cessation services. But also the thing that is important that we can actually have an impact in the terms of decision making regarding the antiretroviral treatment is linked to how high their cardiovascular risk is. Because if it's high enough, we know that abacavir increases almost twofold the risk of having an event, and is absolutely required to remove the abacavir from the regimen. And for example, a very popular single tablet regimen containing dolutegravir, lamivudine, and abacavir can be actually, or has been prescribed in the last 5 to 7 years, I believe. And we have some patients who, as they grow older, so they increase the cardiovascular risk, and it's indicated to remove abacavir from this regimen. We have other options. We have actually the option of, for example, changing the backbone and actually introducing tenofovir. But then, as you have mentioned before, that can actually cause kidney, renal toxicity, and also bone toxicity. Or we have the option of just dropping the abacavir. Just dropping the abacavir will lead us to have a dual, a two-drug regimen, basically, based on dolutegravir and lamivudine. Obviously, we have to look very carefully in the history of the patient whether that would be appropriate, ruling out any resistance mutations, or also ruling out that they are co-infected with hepatitis B. Other things that we probably have seen in the past in this type of patients where we are actually just dropping the abacavir, but there are important key points when you are thinking about two-drug regimens. I just wanted to ask you, because this is something that I ask myself around two-drug regimens very much. Sometimes I'm keen to start patients on a two-drug regimen because I know that I actually potentially can reduce the toxicity of the combination. But in many occasions, more often, I am wanting to switch patients to a two-drug regimen. What do you think? What do you think about when you actually want to do that, and what you foresee as the pitfalls of those switches?
So, one of the most important factors that you need to take into account when you're switching from the 3-drug regimen to 2-drug regimen is whether a person has got a fully sensitive virus to both of those agents, because you would never want to compromise the efficacy of the antiretroviral treatment, and that you touched on before. The other very important point is always to consider the presence of co-infection, in particular hepatitis B co-infection. So definitely people that have got a chronic hepatitis B infection would not be eligible for a switch to a combination of dolutegravir and lamivudine, if not also on an additional agent for their hepatitis B. This said, I think there are other factors that are important to consider, like if I know that a person might have issues with a neurocognitive impairment, or there are any queries in regards to potential viral escape, I wouldn't be comfortable switching those patients.
So that's a very important point, I guess, that we are not used to think too much about, but we probably need more data about, which is the replication of the virus in sanctuary sites where the drugs might not reach fully into, such as, for example, the central nervous system, or maybe sometimes actually we think about the genitals as the other sanctuary site within the body. So do you think that we have enough information or information against 2-drug regimens at the moment? It's something that, I keep looking into when we have conferences, and there is not much coming along in those terms. Have you actually thought about that recently?
I absolutely agree with you. I want to see more data in regards to this particular situation, as well as other situations like presence of very advanced HIV, where you have people with CD4 that are well below 200, and perhaps even affected by opportunistic infection. I'm sure dual regimen would potentially work, and I just would like to see a bit more data on it. Borja, in your experience, would you be more concerned of putting a person on dual treatment with dolutegravir and lamivudine if it's not fully adherent to antiretroviral treatment?
So, of course, from all what we have learned about triple therapy and how, initially highly active antiretroviral therapy came along by combining 3 different drugs, trying to basically avoid resistance development. If the patient has got a suboptimal adherence to treatment, that would be my main concern regarding dual therapy. So I do believe that the combination of dolutegravir and lamivudine works very well in terms of efficacy when it's taken appropriately. And when it's not taken appropriately, so we could see probably blips. The evidence doesn't necessarily support my concerns in the sense of we might not see more development of resistance in those patients who fail treatment on dual therapy. But it's something that I would really like more evidence in terms of real live data. Something that will actually tell me how not only clinical trial participants have kind of experienced their adherence and what the outcome was, because they are kind of ideal patients that participate in trials.
However, I think the data from the trials is reassuring, and it doesn't seem that 2 drugs, in particular the dolutegravir lamivudine is performing less well than the triple therapy, also in people with less than optimal adherence. But of course, we need to support our patients and try to make sure that their adherence is as high as possible. As you know, medication will work if you take it.
Fantastic point. I can see that there is also other things that we can do. It's not only thinking about the type of regimen, but for example, aiding the patient to actually set up alarms to potentially be able to take the medication, or also, which could be a very good point, try to monitor the patients a bit more closely through a period of time, just to reassure ourselves, and maybe actually we could report some of those data to the wider medical community to reassure them as well.
So please follow us on the next episode, where we're going to talk about what matters to patients and patient treatment outcomes.
We'd like to thank the faculty involved in this production. Don't forget to stay tuned for the next episode. Meanwhile, you can explore more HIV content online on the Medthority HIV Learning Zone. Simply register and log in at www.medthority.com. Thanks for listening.